Okay.
Hello, Dr. Panzer.
Good morning.
Oliver.
Oh, good evening, rather.
Hello. Good evening.
Yes, good evening in Asia.
Yeah, good evening in Asia. Good morning in New York.
Right. What time is it in New York, Oliver? What time is it? 6 o'clock a.m.?
It's 5. Yeah, it's 6 o'clock. Yeah.
6 o'clock. Okay.
6 o'clock in the morning.
Earlier.
Okay, it's around 2 minutes.
Yeah.
Yeah.
Okay, I think we can begin now. Okay. Good morning or good evening, everyone. This is Mickey from Wisconsin Medical. Welcome to join this global webinar on Wisconsin Dental College. Today, it is really our honor to invite Dr. Cano, Dr. Panzer, and Dr. Valera here. Now, let me give a brief introduction to Dr. Valera at first.
Okay. Thank you, Mickey, for the nice introduction. Hello, everyone, and welcome to today's webinar. I am Dr. Valera, President of the Philippine Society of Anesthesiologists. We are an organization dedicated in improving the life of anesthesiologists, particularly their knowledge on new trends, access to continuous development, and collaboration with other partners in the medical industry. Now, here in the Philippines, we are now in our 6th month of our general community quarantine, and our engagement is again virtual, as we in the PSA is in the forefront of providing medical updates, especially at this time when mass gatherings and face-to-face meetings are not allowed. For today, I am indeed very happy and grateful to Visonic Medical for partnering with the PSA for this event. For the past several months, Visonic Medical has been having this series of webinars on teaching and sharing ultrasound applications to anesthesia, pain management, and ICU, among others. And in the light of this COVID-19 pandemic, the use of ultrasound becomes very relevant. This technology allows us to perform our blocks much better with greater success rates. And number 2, through the point of care application and use, it allows practitioners of anesthesia and critical medicine a better basis for medical management and intervention. So to all attendees, anesthesiologists, internists, critical care specialists, pulmonologists, radiologists, infectious disease specialists, and other specialists. Welcome again to this webinar. May this be a great learning experience to all of us. Now, I'm also the moderator for this live webinar, and let me remind you a few things. Before we begin our lectures from two speakers we have this evening, I would like you to direct your attention to the Q&A and chat buttons in your control panel located in the middle of your screen at the bottom. And should you have any questions during the course of the lectures, please write it down and submit it so we can have our guest speakers answer them during the Q&A segment. Now, allow me to introduce our first speaker. Dr. Pen Cano is a good friend of mine. Pen Katangi. She's the sister, by the way, of a surgeon of mine, a pediatric anesthesiologist. She's very accomplished. She's an associate professor at the Department of Anesthesia, University of the Philippines, College of Medicine, and an attending anesthesiologist at the Philippine General Hospital. She happens to be the section chief of regional anesthesia, Department of Anesthesiology, the University of the Philippines, Philippine General Hospital. She has been using ultrasound in her private practice for the past several years, and it is my pleasure to introduce to you Dr. Pen Cano, who will talk on introduction of lung ultrasound. You may have the screen.
Hello. Yes, sir. Okay. Hello, everyone. It's nice to see you. Good evening in Manila and good morning in New York. And hi to other parts of the world. So I'm now going to share my screen. Okay. So, okay. These are the objectives of my talk: to know the basic principles of lung ultrasound, become oriented. Can you see my slides?
No.
No? Wait first. So I have to fix it. Okay.
Now we can see. Yeah.
Okay, so these are the objectives of my talk: to know the basic principles of lung ultrasound, become oriented with the uses and advantages of the different types of probes, to learn the steps on how to perform the lung ultrasound examination, to know the lung signs and be acquainted with the common pathological findings. Now, how did point-of-care ultrasound started? According to history, it started with this man, Daniel Lichtenstein, who is a French intensivist and sonographer. Way back in 1998, he introduced the use of the ultrasound in the diagnosis of problems among critically ill patients. 3 years later, his first book was published. And then a few years later, it was translated into English. The book was such a hit because all of the copies were sold out. Because of his many works on lung ultrasound, Dr. Lichtenstein became known as the father or the guru of lung ultrasound. Some of the advantages of lung ultrasound are as follows. Since it is used as a visual stethoscope, the examination can be performed quickly because now we can see what we can hear on auscultation. Because the machine is very compact, the examination can be done repeatedly at any given time and at any given place. This is especially advantageous to those critically ill patients wherein a trip to the CT scan room would prove to be very daunting. It involves no radiation exposure, and it is more accurate than the standard chest radiograph or physical examination in the diagnosis of common respiratory problems. For the diagnosis of pneumonia, it is a better test than chest radiograph. And if you would compare it to the CT scan, lung ultrasound is nearly as accurate. Now, for the diagnosis of pleural effusion, it can detect as little as 20 cc of pleural fluid, while a volume of 150 to 200 cc is needed before it can be seen on the chest X-ray. Although CT scan is the gold standard in diagnosing acute respiratory problems, based on published data, the result on lung ultrasound is nearly comparable with that of the CT scan. Now, the use of the ultrasound is very timely now that we have this global pandemic. Although a dedicated stethoscope is primarily prescribed only for the use among these patients, auscultation still presents a high risk of nosocomial transmission. The same way goes for the use of the portable chest X-ray, because you have to use these plates among these different types of patients. If you transport the patient to the CT scan, this will be followed by the necessary decontamination procedures, which is risky and time-consuming. The use of the ultrasound can facilitate the triage in the emergency room, which is barraged by a lot of patients. Now, considering that there is a delay in the occurrence of hypoxemia among some patients, and there is also a delay in the result of the COVID test, the robust use of the ultrasound can stratify those patients who can be safely sent home or be admitted at the hospital for more proper treatment. Now, this is an example of a triage protocol that have been suggested by emergency room physicians and from the United Kingdom. These are the most common probes that are used for lung ultrasound examination. The linear probe is a high-frequency probe that provides excellent images of the superficial structures of the lung, like the pleura, pleural lining, and even the lung sliding. But the only problem is it cannot visualize the deeper structures of the lung. The curvilinear probe, which is a low-frequency probe, can penetrate the rest of the lung structures, even the superficial structures, although it will not be as clear as the one with the linear probe. It is said to be the best single probe to use. But since the curvilinear probe is quite bulky because of its large footprint, some angulation is needed in order to eliminate the rib shadow. The phased array probe is much like the same as the curvilinear probe in terms of functions and characteristics. It is actually the probe that is used for cardiac examinations. The only difference from the curvilinear probe is that it has a very small footprint that it can easily visualize the lungs in between the intercostal spaces. Now, the lung is the third biggest solid organ, next only to the liver and the brain. There should be a systematic approach in examining the lung so as you would not miss any pathologic sign that we can see from the lung examination. The most widely used method in examining the lungs is codified as the Blue Protocol, which is short for Bedside Lung Ultrasound in Emergency, which has been introduced by no other than Dr. Lichtenstein. It makes use of a 6-point approach wherein bilaterally they are divided into 3 predetermined points. The first point is the one at the mid-clavicular line at around the second or third intercostal space. With the transducer, you can see here the marker facing cephalad. The second predetermined point or zone is the one at the anterior axillary line at the level of the nipple. So this is the area where we'll pose the transducer at the anterior axillary line. And the third zone is what we call the PLAPS point, also known as the posterolateral alveolar pleural syndrome point. It is called as such because this is the point where you would normally visualize the fluid and also lobar consolidation. So from the anterior axillary line, you would move the probe longitudinally towards the posterior axillary line, and then move it a little bit caudad until we see on the left side of the thorax, from caudad to cephalad, the kidney, the spleen, the diaphragm, and then the lungs. Now on the right side of the thorax, we will be able to see from caudad to cephalad, the liver, the diaphragm, and then the lungs. And so it goes. Now, there was another method which had been suggested by people from Italy, which is headed by Dr. Volpicelli. They showed this 12-point lung examination technique wherein they divided the lungs, the thorax, into 3 zones. The anterior zone is from the parasternal line to the anterior axillary line. The second zone, which is the lateral zone, is from the anterior axillary line to the posterior axillary line. The third zone is at the back, which is between the paravertebral line and the scapular line. These zones are further subdivided into superior and inferior divisions. So we have bilaterally 12 points. Now, although the 6-point protocol, or what we call the blue protocol, would suffice in examining or trying to seal pathologic findings in the lungs, this group of people from Italy and China who have seen a lot of COVID patients suggested that it would be best for such types of patients to have a more thorough examination, since lung lesions would show up in any part of the lungs. And so in order not to miss any lung pathology, it would be best to adapt the 12-point protocol instead. Now, according again to Dr. Lichtenstein, we should be able to master several signs in order for us to determine how a normal lung looks like, and for us to be able to diagnose some pathologic findings based from these lung signs. So initially, for the blue protocol, if we place our probe at the mid-clavicular line between the second or third intercostal space, this is what we are looking at. This is our transducer. We have our skin and subcutaneous tissue. Then we have the pectoralis major muscle. And then below that, you will see the ribs. And in between will be the intercostal muscles. And below that will be the pleural line, which is composed of the parietal and visceral pleura, which for normal individuals, you cannot really recognize one from the other. You won't distinguish one for the other. And sonographically, this is how it will look like. You have here the skin and subcutaneous tissue. This is the thoracic muscle, the pectoralis major. Below that is the intercostal muscles. And between these intercostal muscles, you see these hyperechoic convex structures, which are the ribs. And below the ribs is an acoustic shadow. We call it an acoustic shadow because beyond the ribs, we won't be able to see anything. So it's completely dark. Now, between the ribs, a little bit lower, will be the pleural line, which is composed of the parietal and visceral pleura. And below that will be the lungs. So this is more popularly known as the Bedside. The ribs would connote the wings, and then the head will be the pleural line. The head will be the intercostal muscle, and the body will be the pleural line. Now, when we breathe, this is what we are going to see. You can see here the ribs, then this is the pleural line. It slides with respiration. And in that pleural line will be the sliding between the parietal and the visceral pleura against each other. Now, we are looking at it at the B mode. If we want to investigate more the presence of lung sliding, we can shift to the M mode. And this is how it would look like. This is better known as the seashore sign. Why? Because the thoracic wall is adynamic, so they call it as the ocean because the ocean is quiet. Well, the pleural line is this white horizontal line, which corresponds to the seashore, while the lungs, which is filled up with air, would be the sandy, granular beach. That's why it is called the seashore sign. So this connotes normal lung sliding. Now, this is how it will appear in the M mode. You can see here the thoracic wall. This is flat horizontal line because it is adynamic. Now, this is the pleural line, whereas This is the granular sandy beach, which connotes the lungs, which is filled up with air. Now we go next to the A lines. The A lines are horizontal hyperechoic lines that emanate. It means that there is the presence of air in the lungs. Now the fourth sign is the lung pulse. You can see here some small pulsatile movements. It corresponds to the contraction of the heart that can be conducted on the thoracic wall. If there is the presence of the lung pulse, it means that there's no separation between the visceral and parietal pleura. So you can completely rule out the presence of pneumothorax. Now again, this is in the B mode. We can study the lung pulse further in the M mode, and it would be shown as such. You can see these vertical lines emanating from the pleural line. These vertical lines are called P lines. And those connotes the lung pulse. The next would be the B lines. The B lines are characterized as it is a comet tail artifact. It is long, well-defined, hyperechoic. It would arise from the pleural line and ends at the bottom of the screen. It moves in concert with lung sliding. It erases the A lines. If there are one or two lines present in between the ribs, it would mean a normal finding. They're also called lung rockets. Now, if I may, let's have a little bit of a review. The lobule is the smallest lung unit, which is composed of an alveoli which is filled up with air, surrounded by the connective tissue which is called the interlobular septa. If this connective tissue is filled up with air, what happens is that this fluid becomes interspersed among a tetrahedron of air bubbles. So what happens is the ultrasound wave will be meeting up with this interface of air and water structure such that it will be reflected as streaks of white lines, which are the B lines. So the more fluid there is, the more B lines will be created. If there are 3 or more B lines between 2 ribs, then we call it septal rockets. The more B lines there will be, the lung density will increase, and there will be a decrease in aeration. So there can be a confluence of B lines, which are called ground glass rockets. Septal rockets or ground glass rockets can be caused by interstitial syndrome, which can be due to the following pathological findings. It can be due to cardiogenic or non-cardiogenic pulmonary edema. It can be due to acute lung injury, ARDS, pneumonia, pulmonary fibrosis, and interstitial lung disease. Now we go next to the lung point, which is another sign. Now, pneumothorax refers to the presence of air in the pleural space such that there will be a separation between the visceral and the parietal pleura. That point wherein the visceral and the parietal pleura would separate is called the lung point. Now, others would also call this as the pneumothorax border because it is the point wherein lung sliding would meet up at that point where there will be no sliding. So it will show as such. You can see here that there is lung sliding, but up to this point, you can see that there's no lung sliding. So others would call it as the pneumothorax border aside from lung point. So this is the 7th sign. Now we can further verify this by using the M mode. If the SEASHORE sign would show us normal lung sliding, the STRATOSPHERE sign would show us that there's no lung sliding. They're all horizontal lines because it means there's no lung sliding, so it is adynamic. This is how it would look like in the M mode. So you can see here that there's no lung sliding in the pleural line. And then in the M mode, they're all horizontal lines. Now we go to the 3rd zone, in the blue point, wherein we put our probe longitudinally at the PLAPS point, or others would call it as the costophrenic angle, which is the most bottom part of the lungs. This is where we observe most commonly lung consolidation and also pleural effusion. Now, again, looking back at the right side of the thorax, you'll be able to see the liver, the diaphragm, and the lungs. And then below the liver, you'll be able to see this vertebral column. Now, it does not go beyond the diaphragm because the lungs will obscure the vertebral column beyond the diaphragm. Now, when we breathe normally and our transducer is at that PLAPS point, when the person would inhale, you will see that the lungs will move beyond the diaphragm and the liver. You can see here the vertebral column, which does not extend beyond the diaphragm. So we call this as the curtain sign. Okay. Now, if we see a pleural effusion, it is usually between the diaphragm and the lungs. It appears as an anechoic area between the diaphragm and the lungs. And since the fluid is a very good transmitter of the lung waves, you can see the vertebral column now beyond the diaphragm. Normally, if there's no fluid, you can only see the vertebral column up to the diaphragm. But now you can see it beyond the diaphragm. This is called the spine sign, which shows pleural effusion. Now, this is how it would look like. This is the left side of the thorax. You can see the pleural effusion between the diaphragm and the lungs. This is the kidney, the spleen, and then you can see this anechoic structure here, which contains pleural fluid. You can see the vertebral column under the kidney and also the pleural effusion. So next, we go to the last sign, which is the tissue sign. If there's a translobar consolidation, the alveoli becomes filled up with a lot of water so that the lung parenchyma would have a structure similar to that of the liver. It becomes hypoechoic and solid, very much like the structure or how the liver looks like. So this is called lung hepatization, or others would call it very commonly as the tissue sign. I'm almost done. Now, this is a sample of a lung signs matrix. Based from all the signs that we have studied and I have showed you and enumerated, we can come up with the following diagnosis based from all of those lung findings. Now, before I end, this is some food for thought. In the perioperative arena, point-of-care ultrasound may benefit the patients preoperatively, intraoperatively, and postoperatively. The development of a comprehensive focused curriculum to help the residents master this new technology will surely advance the skills of tomorrow's anesthesiologists. Thank you. Okay, Mickey, I'm done.
Okay. Okay, thank you very much, Dr. Cano, for that very informative lecture. And you have pretty good visuals. And you were able to discuss a lot of the basics that a lot of the anesthesiologists here in the Philippines and maybe some parts of the world will benefit from. Okay. Now, we have another speaker. Allow me to introduce our next speaker. I will consider our next speaker a hero because when he's not giving anesthesia, he was able to treat a lot of patients in the front lines of New York. He happens to be an associate professor at the Department of Anesthesia of the Columbia University Medical Center. And he happens also to be a director of the post-anesthesia care unit of the same institution, and at the same time, a director of the perioperative ultrasound of the Department of Anesthesia of Columbia University. He's a member of the Division of Critical Care and Regional Anesthesia of Columbia University as well. For those of you who attended, I think, the PSA, Philippine Society of Anesthesiologists, ISURA convention last year. Dr. Oliver Panzer also was a speaker in that said convention. Doctors, let us all welcome Dr. Oliver Panzer, who will talk on the ultrasound findings of COVID-19 patients. Oliver?
Yes, thank you very much for that very kind introduction. I know, in these times, we all just do what we do best. We take care of patients. And I'm very happy and I'm honored to be able to contribute to this great webinar. So I'm gonna share my screen. I hope that's gonna work. Desktop 1. And please let me know if you see my slides. Do you see my slides?
Yes, I can see.
Okay. So my task, I was asked to present to you some specific lung ultrasound findings related to the COVID patients that we treated. And I prepared basically 2 classic patients that we've encountered in a similar way quite frequently. And I hope that it's going to give you a little more insight of what's happening or how to use lung ultrasound, or maybe even a point-of-care ultrasound a little more broadly. So I'm going to start with the first case, and this is going to be something you're probably going to be relatively familiar to as well. This was a gentleman in his 70s with hypertension, colon cancer, and a resection in the past. His most recent history, he came to us and he was in the OR ICU. We turned our ORs into ICU rooms because we were in dire need of intensive care beds. And we used anesthesia machines to a large extent in these first days to overcome a shortage in ventilators. And this patient unfortunately developed severe COVID ARDS. He was intubated, he was being prone and paralyzed, and was now supine for about a little less than 4 hours because he started improving. He did have a pneumothorax and a pneumomediastinum in the past, however, that's been improving. There was a suspicion of PE in the past, and he was empirically started on anticoagulation. It was never really, the CTA was never done because of his dire situation, and he was septic with an infection, but he was improving on all lines. And then by the time we encountered him, he suddenly had an increase in vasopressor support needs, so his pressors were significantly increased. At the same time, his airway pressures also increased. His peak and plateau pressures were in the mid to high 40s, and earlier they've been in the mid to high 30s, which already is high, but it was even higher. And unfortunately, we started noting some bleeding from the ET tube, from inside the ET tube, and some melena from the rectum. So just a little more information on him. He had signs of decreasing hemoglobin, so he was becoming anemic. He was therapeutic on heparin. His D-dimer, that in many of these patients, as you probably encountered, they unfortunately have a tendency to be very hypercoagulable. But his D-dimers and fibrinogens actually were reduced or normal. However, his lactate was increasing, and his oxygenation, as you can see here, was quite marginal. He was hypercarbic and hypoxic. On exam, though, he had warm extremities, he had a faint pulse, and he had okay capillary filling. This is his chest X-ray, and this is unfortunately a chest X-ray we've seen quite a bit, but his seemed more dense at that time. You can see here on the. Can everybody see my index, my cursor that's moving on the screen? Can you see that?
Yes.
Okay, good. So you can see here that there's a lot of opacification in both lungs, barely any kind of clearer areas, and we were worried about this increasing homogeneity here. with the bleeding. And we also did an abdominal ultrasound at the same time. And here the report came back that this is a so-called gasless abdomen, which one of the worries is that there's ischemia. Again, in the setting of hypercoagulability, even with anticoagulation, that was a worry of ours. So when we started using the ultrasound, we basically had 5 big questions. We were worried, is this driven by what's going on in the lungs? Is this worsening ARDS? Maybe a large pleural effusion is causing these higher difficulties to ventilate. Even with intrapulmonary hemorrhage was a worry of ours, or a worsening, a reopening of the pneumothorax, or was the hemodynamic consequence more a hemorrhagic shock with the signs of bleeding and the melena, or a recurrence of sepsis or worsening RV failure and a PE. So you can see that, especially if you have these patients that are already been around for a longer time, since the complexity of COVID is so broad in terms of the organ system that it can affect, it becomes very difficult at a certain time point to really pinpoint exactly to what might affect the worsening or what the reason is of the worsening hypoxia and many times associated shock. So lung ultrasound and ultrasound in general really comes in very handy. And for the first slides, I'm just going to go in a little more detail how I did my lung ultrasound exams. And for the second patient, I'm going to be a lot briefer about this. So typically the way I start is as Pen alluded beforehand, there are different models. I do a screening exam first, where I basically have a 4-point exam where I start laterally with the diaphragm or the PLAPS, and then I move forward, move up to the lateral above the diaphragm and go anterior. So I have a total of 4 points I examine per half chest. So what you see here is the right diaphragm right here. You can see this bright line. You have the liver underneath. You have the kidney. This is the Morrison pouch. So you can see here, there's no free fluid. There doesn't seem to be a lot of effusion. You can see here a little bit of black fluid right there. But other than that, you see a lot of lung rockets. So this is probably lung with some pulmonary edema or increased lung density from the ARDS. I moved up laterally a little bit. I'm sorry about that. And you can see that there's tons of B-lines, like you've seen earlier already, but you can see here that within one window, here's a rib right there. This is the pleural line. And you can see that tons of B-lines coming off, even some of them so-called confluent. So they're really bundled together. You can't differentiate them as one, which is a classic sign for what we've seen in COVID ARDS a lot of times. And these typically, if you look at the CT scans, these bundled B-lines correlate to ground glass opacities in the CT scanner. So just to show you what's happening at the pleural line, here I've added a lung exam with a phased array probe. So you see the cone-shaped picture. I like to use phased array probe most of the time, especially if I'm dealing with ARDS and assessment of pleural effusions, because it allows me to go deeper and I still see the pleural line well. And you can see here, if you look at the pleural line, which is the first line on the right picture, it's different. This line in ARDS, in an infectious disease, it's basically thickened. You see how irregular, it's a little fuzzy, whereas here it's nice and sharp and a thin line. So that's a classic sign of ARDS, especially if it's related to an infectious disease. Here I move to the anterior segment. You see similar findings, and you can appreciate the irregular pleura right here. And this is more in the midsection. And here I want to highlight that there are some, going back again, you can see that not only is the pleura thick, but you can see these little indentations, these black areas right here with even some deeper reaching white matter and then sending off lung rockets or B-lines. And these are, most of the time, these are peripheral infiltrates, small infiltrates by either infectious agents. Sometimes if they're a little bigger, 1 to 3 centimeters, a PE can present like this, like a wedge-shaped structure at the pleural line. We're going to talk about that a little bit later. And here again, the topmost, and again, not only is the pleura thickened, but you can see these fragmentations, we call it, these interruptions of the pleura, indicative of an inflammatory or infectious disease process. Now I'm switching to the left side, and you can see here, it's a little harder to visualize because on the right side, I have the big liver that offers a great acoustic window to the deeper structures like the diaphragm. Whereas on this side, I only have the small spleen, which is more difficult to visualize, but it's, suffice it to say, I still see it right here. There's movement on the diaphragm. I don't see the spine sign, unfortunately. And you can see here, this all looks pretty dark. And you, in the beginning, you might be, mistaken by calling this or thinking about this as fluid, but as Penn highlighted before, you can only call this fluid if you clearly see the spine sign underneath. Otherwise, this is probably just an artifact and you can't really tell. You see here like the bottom of the lung sliding into the recess. Now, again, further up on the left side, again, a markedly thickened pleural line with irregularities, tons of B-lines coming up, suggesting ground glass opacities. Here again, same finding with some interruptions here. Some, you can see here like a little bit of a small layer of fluid that's classic to surround peripheral infiltrates in severe pneumonia or ARDS. And that's at the very top. And again, you see here, these are tons of confluent B-lines, so ground glass opacities overall. So, overall, this confirms a picture of like a severe ARDS or severely increased lung density that could go along with ARDS. I want to quickly highlight a study that's been done by Dr. Papetti that Penn mentioned earlier already. He did a lot of work in that regard. And he early on already developed signs in a study where he tried to differentiate just by lung ultrasound classic features of a high pressure pulmonary edema, like a cardiogenic pulmonary edema, versus a pulmonary edema or increased lung density that would be more associated with ARDS. And you can see here the white columns representing the patients who have ARDS versus those who have classic CHF, like heart failure, in the black columns. And you can see while all of them had the B-lines and pulmonary edema called here alveolar interstitial syndrome, AIS, only the ARDS patient had lung sliding that was reduced or absent. And you saw that earlier, that the lung sliding that you've see in normal patients is not as ubiquitous, not as large. The amplitude is not as large as it is spared areas, which unfortunately with patients, COVID patients, are rarely seen. These are areas that look normal, meaning they have A lines in the middle of having tons of B lines around them. Consolidations, many of the ARDS patients, but none of the heart failure patients had them. And consolidations we do see, but mostly the peripheral ones, not the classic big ones. And the lung pulse also was more present in ARDS. So you see here, there are like several lung ultrasound findings that already can point you towards the etiology of the increased lung density or pulmonary edema. And other than the distribution, typically ARDS is inhomogeneous spread, where CHF doesn't spare any areas. This is a classic spared area with ARDS. You can see here, you see the thin pleural line, you see the A lines right here, and then you have these confluent B lines next to it. Unfortunately, COVID ARDS, we didn't see much of those. The lung disease is just too severe, whereas in CHF, you typically have no sparing. You have the lung sliding present, but you have the changes of the pleural line in ARDS are more common. You see that what I showed you earlier, really the broad, like a fluffy pleural line compared to a sharp pleural line with a non-inflammatory process like CHF and pulmonary edema. Lung sliding is many times is absent or reduced in ARDS. The lung pulse many times is present in ARDS because it's a precursor of a complete atelectasis and collapse, which is rare in CHF. And the consolidations also more likely in ARDS. But again, COVID is a little different. And typically pleural effusions are able to be seen in both. But in ARDS, they're typically small, whereas since this is a high pressure pulmonary edema, pleural effusions are more likely to develop. I want to quickly spend some time on talking about consolidations in a little more detail. And you can see here, oops, this is, it doesn't play, okay. So this is a classic lung consolidation that's really big. You see a lot of effusion fluid around it. You see the diaphragm right here. You can see the liver, and you see the lung. And the lung really looks very much like the liver. We call it hepatization. It's hypoechoic. It's gray like the liver. And it has air fluid bronchograms. These are quite important later on to diagnose things like pneumonia or aspirations, where you see here these black streaks are fluid-filled bronchograms, whereas if you have these white streaks or white dots, these are very likely mucus air bubble mixtures that are in the small airways. How does this happen? Basically, the alveoli represented here are being filled with fluid and cellular debris. And by that, all of a sudden, ultrasound is not reflected completely at the pleura, but is able to kind of depict by traveling through the solid tissue or fluid and show the lung as a solid organ. It is not clear just by looking at a consolidation what caused it, what's behind it. There are more signs that you can look for, but it probably would go beyond this webinar. I want to highlight that consolidations can come in all different shapes, and they can be large or small. And these are small lesions. This is anywhere from 0.5 centimeters to 2 centimeters. This is what we've seen most of the time in ARDS. These are small at the pleural line, small layers of fluid, anechoic layers, and then these dark areas, small areas that have sort of shredded lung at the border with a lot of comet tails coming off, and small heterogeneous white spots, white streaks, again, air bronchograms, fluid bronchograms in the middle. Here, this is a PE in the periphery. It has a very distinct shape. It's wedge-shaped. It's 1 to 3 centimeters, sometimes has a white dot. Or if it's very homogeneous, not irregular like this, it's more likely to be a tumor. But what we've seen many times in ARDS is this middle picture. And I want to highlight this here. And you can see here all these little indentations at the pleural line. Here it's even interrupted. So these are all signs very specifically for an inflammatory infectious process in the lung that's causing the pathology. In this patient, because we were worried about pulmonary hemorrhage, that's what I would have expected if there was significant pulmonary hemorrhage. This is a large consolidation right here. So just to orient you, here's the diaphragm. This is the liver. And again, you see the texture between the liver and the consolidated lung is very similar. And here you see like the small bronchi that I visualize. And you can see these white streaks that with insufflation, they get broader. This is basically a sign that this has been an occlusive process. And you can see some fluid bronchograms, these black streaks on top of it, that there's been either an aspiration or mucus plug that's causing the collapse and consolidation of the lung. And this would be something that I would be looking for if I think about intrapulmonary hemorrhage. What I want to highlight is that all the signs that we've talked about lung pathology are basically a continuum of worsening pathology. So you start with a normal lung with A lines. The moment you have B lines, you know that there's worsening lung density pathology, and it evolves to ground glass opacities, which are these confluent B lines, and end up ultimately in the lung collapse and consolidation. What's important to highlight, though, is if you treat these patients, you do regular exams, you can use this as well to kind of get a glimpse of improvement. because if you had consolidation beforehand, now you have confluent B lines. This is a sign of improved aeration of the lung. So it goes both ways. It gives you an idea if you do repeated exam if the patient is worsening, but it also gives you an idea if the patient is improving. And we use this quite a bit during the COVID crisis. So going back to the questions that we asked ourselves initially is like, what's the reason for this patient's worsening respiratory mechanics and oxygenation, worsening pressors? And one question was this worsening ARDS. Certainly there are signs of ubiquitous and severe ARDS in this patient, but it didn't look that different from what's before. So it was hard for us to say if this was really the reason for the underlying process. Then we had the question of the pulmonary hemorrhage. We said unlikely because that's why I highlighted consolidation process, because we did not find these solid consolidations with as an evidence of plugged mucus plug, blood clot plugging of the smaller airways. And so I thought it was rather unlikely that this was a large bleed. We later on did a bronchoscopy and confirmed that there was not a lot of bleeding inside the lung. The other question was large effusion and hemothorax, and you saw, especially with the exams that I did on the side, there was no large effusions, no indication of a hemothorax. So we could rule that out. And the pneumothorax was a worry that this was worse and caused the decrease in venous return and high peak airway pressures. But we've seen lung sliding very well in all sectors. Even though it was reduced, it was present. So we effectively ruled that out. So lung ultrasound in this patient already helped us narrow down quite a bit of differential diagnoses. This is just to highlight again how to diagnose a pneumothorax. But Penn mentioned a lot about it, so I'm just gonna skip over this. This is a lung point for a partial pneumothorax. We've seen that a lot. Most of our pneumothoraces in these patients been partial pneumothoraces. And I just want to highlight, this is just because I think the picture highlights this very well. You can see at the pleural line highlighted by the blue arrows, you can see the expanded lung. You can see by the moving pleura, but you can see that both sides look very, very similar because both of them have A lines. They have a pleural line, they have A lines. This is a rib with the shadow. So the only real difference is the moving pleura on the side of the partially collapsed lung and the absence of sliding on the air side of the pneumothorax. And this is the so-called lung point. You can see that the pleural line also is somewhat thicker and brighter when you have both sheath, the pleural and the visceral and parietal sheath rubbing against each other. Where in here, where you only have the parietal sheath, it's thinner and less bright. And this is how to imagine the lung point appearing. So I want to switch, and I highlighted this earlier, I want to quickly switch to a cardiac exam that I always do, and I teach that as a necessary step to really assess the pulmonary cardiovascular system well. I don't think it's wise to just stop at the lung ultrasound alone. It's always recommended to add at least a few views to see what's going on, because the lung and the heart, as we all know, are very closely intertwined in how they respond to disease. And here I always start with a subcostal four-chamber view. In these patients, high PEEP, high airway pressures, the lung is overblown. You have a hard time for those who do echo a lot. You have a hard time to see anything in the parasternal or in the apical views. So the subcostal view is really a great access for these patients. And you can see here, this is the right heart. This is the liver on top, the right heart, the right atrium, the left atrium, the left heart. You can see just even if you don't do routinely echo, this seems to be squeezing quite well. What we like to look at is at the tricuspid annular ring right here between the atrium and the ventricle. And if it moves up and down really well, that is an indicator of a good RV function. You can see right there, there's good movement along that area. So there's pretty good biventricular movement in this patient. I always like to look at the IVC, which is now a longitudinal cut in the same area where we got the four-chamber, subcostal four-chamber. And you can see here the IVC looks pretty plump. It's typically about 1 to 1.5 centimeters. This here looks like almost 2.5 centimeters. There's still some oscillation. We like to use the M mode with it, and you can see these waves that go along the IVC wall. These are the cardiac oscillations going from diastole to systole. As long as you see these waves, in my mind, you know that at least the preload conditions for the right heart are still within a normal range. But the width of this suggests that there's a lot of preload to, or sufficient preload to the right heart. So hemorrhagic shock, bleeding, massive bleeding becomes very unlikely. Another view from here is just by using the same plane that we use for the IVC. So the ultrasound plane is going from head to toe, and I'm just swinging it, I'm tilting it over to the heart, and I get all the short axis view that I'm used from the parasternal short axis and long axis. And you can see here, this is the RV, this is the diaphragm, this is the liver, and my ultrasound beam is right there in the epigastric area. I scan through the liver, and that's why I see the heart really well. You can see at the periphery here that all these rocket tails, lung rockets, suggestive of this ARDS. But you can see the RV is small, the LV is small, it's contracting really well. And we've seen also a short axis view at the aortic valve level into the PA. In these patients with the high PEEP, high airway pressures, RV failure is always a concern. This is way too advanced, but I'm just showing it because we did it. We used Call Doppler to see where the flow is, and we looked at what the stroke volume is of the RV. And you can see here the stroke volume signal. This downtown, it's nice and broad, and it has a good velocity. So very suggestive. You could do this more detailed, but it would go beyond this, of a good RV stroke volume. And I think these patients are important because of the hypercoagulability to quickly look or make an effort to look at the femoral vessels to look for DVTs. And again, there are no DVTs. This was clear here in the veins underneath the artery. We expanded this because of the abdominal X-ray, and this is just an incident finding, but that I found very interesting. You see here small bowel loops on the right lower image here. You see two. One that's clearly moving has good peristalsis. For a small bowel, actually quite a bit of peristalsis. And you can see another piece of small bowel that actually looks thickened and does not move at all. So it kind of did not, that is suggestive or raises the suspicion for like a pathological process like ischemia. And with these patients being so hypercoagulable, we decided to do a CTA of the mesenteric arteries to rule that out. And here you can see the bladder with the Foley balloon in the right position, which is a thing I do when I do scan the ultrasound. And so back to the questions that we had initially for the worsening pressure requirements and hypoxia, septic shock. It is possible. The heart is working very well. It's a little bit on the hyperdynamic side. There are no other big explanations for why the blood pressure was dropped. So a septic shock, it kind of fits the picture. There is, excuse me, RV failure and strain. That seems unlikely. I have a small RV, I have good RV stroke volume, I have good function. Yes, the IVC is a little plump, but there's still the cardiac oscillations in there. It makes a florid RV failure as a reason for the hypotension very unlikely. And hemorrhagic shock as well because of we ruled out the free fluid in the belly in the case. So the second case, very similar, 52-year-old gentleman, 32 days with COVID, was improving, but then had increasing vasopressor support and a worsening oxygenation. And you can see here worsening anemia, renal failure, a classic in these patients, lactate increasing, suggested for poorer perfusion, leukocytosis and increasing procal, and marginal oxygenation and ventilation. Cooler extremities on exam. You see that here the infiltrates are less pronounced than on the prior patient, but still has quite a bit of ventilator requirements. ET tube was okay. Our key questions were, is there a pneumothorax? Because the high sudden increase in airway pressures, septic shock, hypovolemia bleeding, as these patients are severely coagulopathic and can go both ways, or worsening RV failure as part of the shock and hypoxemia. I bundled all the findings for the right lung. You can see here we have a positive spine sign in this area and a little consolidation with a small amount of fluid, a classic finding for us. You can see again the interruptions, the fragmented pleura, the small peripheral infiltrates up here. Also thick line, tons of B lines, so classic for ARDS. And you can see that the chest X-ray really, if you compare the two from the first patient, suggests that, oh, maybe this patient has less disease. But if you look at the lung ultrasound, that's not the case. Again, the base exam here, you can see here, you could mistake that for consolidation because it's gray. It has all these little punctures in there, but you don't see the spine continuing above. So this is not a consolidation or pleural effusion that's in here. These are lung artifacts from the peripheral pleura. Again, you can see here the midsection, you see the heart, so I'm close to the parasternal short axis view. You see a less affected area with an occasional A-line, and then you see consolidation, peripheral consolidation with all these marks right here. So that's an evidence of sort of a spared area here, B-lines, A-lines right there, and then consolidation even next to it. So classic for ARDS, and here again, the fragmented pleural line. So very clearly, this is ARDS, but again, is that the reason why this patient is getting worse? It's difficult to say, it could be. The pneumothorax, we saw lung sliding everywhere, not the case, so clearly ruled out. Switching to the cardiac assessment, you can see here, I did my subcostal view again, and now this is a little different. If you look at it closely, the LV is very hyperdynamic. It's small, you can see here. Compared to that, the RV looks big. And if you look at the TAPSE, the ring here, it's not moving as vigorously as in the prior patient. So there are signs that there may be RV strain and dysfunction. Again, subcostal, this is the liver, this is the pleural, peritoneum. And here you have the diaphragm in between and the pericardial sac and then the heart underneath. I looked at the IVC, and again, here the IVC, again, it's plump. It's more than 2 centimeters. And you don't see these nice oscillations that we've seen before. So there's a sign that actually the RV preload may be excessive. And if you have the 4-chamber view, you clearly see the increased size of the RV. And here we measure a classic TAPSE that's an M-mode function going through there. And you can see that the amplitude here is very small. Normal is 1.6 centimeters. You can see that's less than half. A sign of severe dysfunction. And then ultimately here, you have a parasternal short axis view. You see a classic sign of RV strain and overload. You can see the flattening of the septum, the so-called D sign. So this patient clearly had evidence of increased RV afterload. This could be through ARDS and high pressure ventilation alone. But in this patient on the short axis at the aortic valve level, we actually did find a PE right here with a questionable clot in the RA. This is the central line that he had. So there was a high suspicion for PE. We did the vascular ultrasound, however, he did not have PE, DVTs at the bottom. So going back to our questions, we ruled out a pneumothorax. And yes, is septic shock possibly has increased leukocytosis and procalcitonin. Septic shock produces isolated RV failure. We know that from studies from Villar-Baron in France. But given the severe RV dilation and dysfunction, we're worried about a different etiology. And clearly we found it, the PE. However, these ARDS, the high ventilation pressures, are still able, and sepsis, to contribute to the picture. And what we did is we basically started heparin, we increased inotropy, we started Lasix, we decreased the PEEP, which is always difficult in these patients because it may make it worse. And we changed, broadened the antibiotics. So in summary, what I think in COVID, what we've seen is classic signs are really increased signs of increased lung density, confluent B lines most of the time, ubiquitous spread. We did not see many consolidations in the classic sense, like the big ones, but we saw a lot of the peripheral pleural infiltrates, almost a hallmark of this disease. Thickened pleura with fragmentations, a lot of it. rarely pleural effusions, especially large ones, mostly the small ones that I showed you. And pneumothoraces, they were not very frequent. I would say 8 to 10% of the patients probably developed them, especially if they were on the ventilator for a long time. But they're very important to keep that in mind as a differential diagnosis when the airway pressures go up. Also, I hope I showed that it's really valuable especially in COVID patients, to pair the lung ultrasound with an echo and a vascular ultrasound, because of the COVID affects so many organs, like the myocardium, like the coagulation system. And what we found as well is that actually handheld devices, the smaller devices that work with laptops or phones, work very well because they're less bulky, they're easier to clean. So a lot of people were hesitant initially, in our case, to use our traditional ultrasound machines more frequently, but the handheld devices made this a lot easier. And most of the time, basic scanning is enough to be able to work through a differential diagnosis list. That's it. Thank you very much.
Okay, thank you very much, Dr. Panzer. That was a real exhaustive and a very nice lecture. Okay, we have learned a lot from your lecture, Dr. Panzer. Thank you.
Thank you.
And at this point, I think Mr. Joseph Kudyamat would like to present something, and he would be presenting the products of Visonic for possible use, maybe in the Philippines or in Southeast Asia or Asia. Okay, you may have the screen, Dr. Kudyamat.
Valera.
Yes.
Thank you, Dr. Valera. I'll be sharing some PowerPoint for you to see our product. Hello, are you seeing my PowerPoint?
Yes. Yes.
Thank you, Doctor. Thank you.
Yes.
I'm Joseph Kudyamat, and we are representing Visonic here in the Philippines, together with our partners, company partners, GEP Solution, and also GCMed Pharmaceutical. With Visonic ultrasound series, we have 4 types of ultrasound: Piloter, Clover 60, Navi, and Labat. To describe Piloter, it's a tablet unit or a desktop that can also be used for trolley. It has a 30.3-inch touchscreen, and it weighs 1.9 kilogram. It has 1 probe transducer port, but you can actually extend it to 3. It has a needle tip enhancement technologies, and cloud service for teleconsultation. It has a broad spectrum of clinical application like anesthesia, pain management, emergency, MSK, cardiac, and general imaging. Our laptop series is Clover 60. It has 4.9 kilos and 2 transducer ports, but you can also expand it to 3-in-1 transducer extension. It has a magnesium case, so it's more durable and lighter. Needle enhancement solution, education center, and cloud service for teleconsultation. It has also applications for MSK, cardiac, 4D, pain management, anesthesia, emergency, and ICU. For our Navi, which is basically used for anesthesiologists, it has a 19-inch touchscreen, electric adjusted trolley. You can also expand it with 3-in-1 transducer extension, and you don't have to worry about power because it has 7 hours powering batteries. We show teaching, recording, education center, and needle tip enhancement technologies, and cloud service for teleconsultation. Application anesthesia, pain management, emergency, MSK, cardiac, and general imaging. And for our labat, it has a full field focus imaging with high-end hollow beam platform. It has the latest hollow beam imaging platform, an AI technology for nerve identification, 6 hours battery, 4 transducer ports, electric adjusted trolley, and button probes. It has also cloud service for teleconsultation, education center, visual teaching recording, and needle tip enhancement solution. Applications also include anesthesia, pain management, emergency, MSK, cardiac, ICU. And these are the special features of all of our ViSonic ultrasound. It is the hollow platform, which has 3 sample gates to evaluate 3 positions in 1 heart cycle. It measures across the spectrum in same phase, available on convex and linear, more accurate and efficient. It has also an auto Doppler, a 1-button auto Doppler, which adjusts ROI position and angle, PW sample gate position, angle, and size. It applies to vascular exams. It's easy to use, and it will save you time. And for more advanced models, we have a WeNerve AI, an AI technology to identify the nerves and muscles automatically. WeNerve AI is a multi-template BP at interscalene SC AX, femoral nerve and sciatic nerve. It will greatly shorten your learning curve and the cloud evolution more accurate. How WeNerve works. Needle visualization solution, WeGuide, magnetic needle track technology, and intelligent needle enhancement technology. And we also have our video recording feature. So you can be able to upload to Twitter, Facebook, LinkedIn, so you can get likes and or comments, and teaching lessons for academic exchange. So this is how our cloud service works. With our QR code rapid scanning, you will be able to share your clinical case through your iPhone, your Android phone, pad, and the storage is fast. And this will also can be used for remote after sales service. So you don't need to have an engineer on site, but we can actually give service remotely with our WeCloud service. This is our remote diagnosis. This is the real-time teleconsultation with images, videos, and audios, and real-time remote diagnosis via WeCloud. And with this system, our engineers or tech people will be able to remotely control your ultrasound, so the maintenance cost will be reduced. Our user peers. So thank you for listening. This is our contact bill, and you can give actual demo or hospital. So we will just give us a call or email us for any schedule for that demo. Thank you.
Okay, Joseph, thank you very much for introducing your products to us. Be sure to leave your contact number and email address to the Philippine Society of Anesthesiologists office, so a lot of the practitioners will be able to contact you. And thank you very much. Now we will proceed to the exciting part, the Q&A portion. This is always exciting in webinars. And I would like to have received a lot of questions and allow me to read them for you. But first, I have a phone-in question, and I think this is directed to Dr. Cano. Is the skill easy to learn? And the second question is related. Can we use it as a screening diagnostic tool to classify COVID suspect and probable patients? Maybe Dr. Panzer can answer the second one. So, Pen, is it easy, a skill, easy to learn?
Basically, because I do a lot of regional anesthesia. So I already know how hypoechoic, those terms, those sonographic terms, anechoic, and how they look like. So when I started to learn point of care ultrasound, it was not hard for me because I already know the sonographic images and how they look like. But for other people, like if you are basically a newcomer into the world of ultrasound, maybe initially it will be like kind of a steep ladder. So you have first to become oriented with ultrasound images, and then perhaps from there, you can start learning all the other basics with lung ultrasound. Basically, it should be learning first all the lung signs. And from there, once you learn the lung signs, then you can gradually become more advanced and you start to try to diagnose other complexities on lung pathology. Because point of care is not only lungs. If you have seen the lecture of Dr. Panzer, he has shown us a lot of other things which involve point of care. Because if we diagnose lung pathologies, like for example, if we are considering pulmonary edema, the cause can be cardiogenic or non-cardiogenic. So you also have to look at the heart. So you cannot separate one from the other. And there are a lot of other entities to be studied with point of care. So it's quite a learning that is vast, but of course you start first from the basic and from there you progress. And then you have to keep on really attending workshops and then apply it when you go to your hospital.
Thank you very much, Pen. So the answer is, it's easy but not easy. But you can teach old dogs new tricks. Can we?
Right,
Pen?
right.
Right,
Yes.
okay. Okay, Dr. Panzer, can we use it as a screening or a diagnostic tool to classify COVID suspect and probable patients? What do you think?
I think to be honest with you, from the COVID patients that I've seen, the lung ultrasound is sort of not necessary to classify because it's a clinical assessment, right? I mean, they are very, very hypoxic. And by that, you can confirm a lung process and then confirm ultimately that, this COVID patient has COVID ARDS. But I think to classify them, they do have, even those that have milder symptoms, do have quite a bit of lung pathology already. So I didn't find it that useful to kind of help me, decide, for example, a need for intubation or not, or, determine the course of it. But I did find it helpful to kind of see if I have signs of improvement or signs of worsening and judge my therapy therefore. I think for classification, the clinical aspects are probably what drives the decision.
Very well said, Dr. Panzer. Okay, there's another question, Dr. Panzer. I think you will be able to answer this. The question is, since ultrasound is a real-time diagnostic tool, can we use it also to check if mechanical ventilation settings are able to open up spaces or identify if there are fibrotic changes in the lung parenchyma already? So
this is a great question. Actually, yes, I think you can, and that's what I was alluding to by describing the lung findings as a continuum of worsening or improving. So there's actually nice studies out there that use that in critically ill patients on the ventilator to see if a pneumonia is improving. So meaning, does a consolidation go from consolidation to confluent B lines or even separate B lines? Then that is a clear sign of improvement. And I do think that it is very useful for that, to actually see if you're making progress. Now, the last question is actually tricky. You mentioned lung fibrosis. And for lung fibrosis, that looks very similar to spread out B lines. I don't think it typically comes with confluent B lines. It's more like separate B lines because of the fibrotic process. But you cannot distinguish them from an acute process. So they look very, very similar. So the only way, and I've mentioned this a couple of times, I think the key with doing point of care ultrasound in many aspects is the key is to do it repeatedly. So you track your patient over time, and then you get additional benefit to see. Because if you start then a patient that comes with pre-existing disease like lung fibrosis, but you know that from the beginning, you'll be able to change your clinical assessment as if you didn't know that, or let's say the patient initially did not have a lot of B lines and then chose to have a lot of B lines. Lung fibrosis is unlikely. Then, the reverse, of course, is true. If the patient gets better, and we know from reports that these patients exist that develop persistent lung fibrosis afterwards, the lung exam just doesn't change, right? So the B lines stay there, even though the COVID in and of itself is the virus and the inflammation is gone. So fibrosis so chronic versus acute changes, hard to make that diagnosis specifically with a lung ultrasound exam without having the clinical information and a time course.
Thank you very much, Dr. Panzer. This next question is directed to any of you. How do we differentiate a consolidation of pneumonia versus collapse? Ben, maybe you can answer first.
No, Dr. Panzer will answer that. He has more experience on consolidation and collapse.
So there are different signs from collapse. So typically a collapse is by external pressure. And so you have to have signs of that. And classically, in our case, that's a large pleural effusion. So it's hard to think of a collapse if you don't have a compression. And with a compressive atelectasis, a true collapse by external pressure, you don't have other signs like what I mentioned earlier, the air bronchograms, which are white dots within the solid lung, or black dots or streaks within the solid lung. That doesn't happen with a complete collapse from external pressure. Pneumonia, you can actually diagnose now fairly reliably because there is a list of criteria that make a pneumonia more likely. But again, the key mark is here, it fits the clinical picture. But if you have a clinical picture that could suggest pneumonia and you have a thickened pleural line, a fragmented pleural line in one area, if you have dynamic air bronchograms, I showed you one picture where the line actually extended with an inspiration inside the consolidation. This is very typical for pneumonia because what it tells you is that if the air bronchogram is moving back and forth, there's still air being pushed into that segment of the lung. So it cannot be a complete mucus plug and occlusion that caused this consolidation of the lung. So this dynamic air bronchogram, the change of the pleura, and typically a very small pleural effusion rather than a large one around it, make the diagnosis of a pneumonia very likely. again, I want to highlight in the right clinical scenario, meaning I have signs of infection that would explain that.
Okay, thank you very much, Dr. Panzer. Another question for you, Dr. Panzer. It seems you have a lot of fans over here. The question is, will ARDS, will the signs of, I'm just going to rephrase the question, will ARDS signs show specific signs under ultrasound? How about COPD? Will it show specific signs under ultrasound?
Yes. So,
ARDS.
You mean ARDS in a COPD patient?
Maybe
is that what?
I think it's a different scenario. What signs will appear in ARDS and what signs will appear in COPD under ultrasound?
Good. So yeah, they're very different. In ARDS, we talked a lot about it. We talked about all the signs, and basically all these signs are absent in COPD. COPD is going to show you a very clean lung, meaning in the sense that you're going to have a pleural line and A lines, tons of A lines. The thing is that there in COPD as well, though, the lung sliding will be very reduced. It's going to be hard to see. You would typically, what I do if I don't see it very well on the cardiac probe, I switch to a linear probe because I have a higher resolution to detect really small movements along the pleural line. Because in a COPD patient, the lung is overblown. And so it's very extended, so you're not going to see the lung sliding very well. But the hallmark is that COPD looks like a normal lung, but the patient is very symptomatic. So if you have normal lung and you have a patient who's hypoxic, then COPD, asthma are two diagnoses that immediately pop into your head, including PE that also would show in a severely hypoxic patient, would show a grossly normal lung.
Okay, thank you. Now this is a question addressed to Joseph Kudyamat. Joseph, how much is a piloter? The question is, how much is a piloter? Yes. Maybe
Look, we will send the price quotation once we get the details of the person asking.
Okay.
Because right now it's highly volatile due to COVID season for the shipment. It's very unstable.
Okay.
But rough estimate, it will run to between 800 and to 1 million.
Okay. So we'll send the details to Dr. Arnel Asino. Okay.
Thank you, Doctor.
Okay. So another question to Dr. Panzer again. How reliable is the IVC diameter and other indices to assess fluid volume to rule out a shock or a volume overload?
So that's very good question, very important question. The IVC is easy to assess, and therefore IVC parameters like the variation in diameter have gained a lot of popularity to assess volume response. Unfortunately, this test is very inaccurate. So I would not recommend to decide on a giving volume based on just assessing the variation in size of the IVC. I can tell you just this question alone, I could give you at least 1 hour talk to get through all the different methods of volume responsiveness. What I do think the IVC is very valuable for is to assess extremes, meaning what I highlighted in my talk is that if I do think that the shock, high dose pressors, increased lactate, cold, clammy extremities is caused by hypovolemia, the IVC will not be plump. It will be collapsed. It will be very small. In that way, but that's a very extreme situation. Most of our patients are in the gray zone, where I have a little bit elevated pressures, but my IVC is not completely collapsed. It's just like oscillating a little bit. And I feel like that is not a good tool to make that decision. Should I give like 500 cc's a liter? And maybe that's going to go better, because the downsides in ARDS patients who already have a very poor lung function, if you give a liter based on an IVC exam, it may cause you more harm than benefit. So what I like to use the IVC for is extreme. So if it's very plethoric, I know that, together with other signs of RV dysfunction, there is likely RV dysfunction, and I have to treat the patient as such, and I will avoid volume. If my IVC is super collapsed, sometimes if it's very collapsed, I can't even find it. Then I know a collapsed IVC amongst all the experts that I talk to, like really, really small, almost not visible, that is bleeding and severe hypovolemia until ruled out otherwise. And to give volume there will likely not cause harm. But you see how careful I am to kind of give you that recommendation. But but most patients are just in the middle where you don't know. And there are other assessments like the pulse pressure variation, like assessing stroke volume variation, like I showed you earlier through the PA. If there's a big variation in the right setting, that's more sensitive in terms of deciding if I want to give volume or not. I hope that's a short answer. There's a lot more to say about this. But I do think in general, the IVC variation, even with, positive, and it's only valid, I want to highlight the IVC variation in diameter is only valid in patients who are intubated, ventilated, tidal volume of 8 cc's per kilogram or greater. They don't have any sinus arrhythmia. They don't have any arrhythmia at all. And they cannot have a very stiff lung. A compliance less than 30 centimeters per water column makes this test inaccurate. So you can see there's so many things, especially in ARDS patients, that already throw this method out the window. So if you use it, like I said, use the extremes, blown big, there's likely some RV problem and for sure not hypovolemia. Collapse, almost not visible, there is hypovolemia until proven otherwise.
Thank you, Dr. Panzer. Does it mean, Dr. Panzer, that you're willing to have another webinar and talk about the IVC?
Volume responsiveness, I'd be happy to. That's my special.
Yeah. Good. Thank you very much. Okay, there's a question here because I think you are involved in a lot of the treatment of COVID-19 patients in New York. The question is, what is the protocol of a COVID-19 patient who is in a prone position for treatment interpretation? So what is their protocol for a COVID patient in New York, in Colombia?
So yeah, I mean, there's a whole protocol. I'm not even sure if it's shared or not. I can certainly inquire to kind of share the protocol. It involves a lot of training. It's a dedicated team that does this because in these patients, the process of proning can be very dangerous by itself because you can imagine that, a lot of pulmonary pressures, chest pressures change. There's a risk of pulling lines, disconnections, all that stuff. So it's a very highly specialized team who does that. The protocol, roughly, we see a rapidly worsening course that did not respond to paralysis. That's when we consider patients. Typically, when they're already on high FiO2s and very high PEEP, we do not do proning again. There is a window before you maxed out your ventilator therapy, but you see the course of the patient is rapidly escalating where you can do this. So you need to have enough cardiac reserve, so you need to make sure your patient is not in cardiogenic shock, that it can take it because it will change the preload conditions of the heart. And if you have a weak heart that's just kind of hanging on a thin thread, you're probably going to cause more trouble than benefit. And you have to make sure you're not already maxed out on a FiO2 100%, PEEP of 15. So you need to make that decision just a little bit before, and you need to have a highly specialized team. In our case, it's a team from the medical ICU that is doing that. We in the surgical ICU, we have not had a lot of experience with it because we have a lot of abdominal surgery patients, so they're by definition excluded from like proning. So there are a lot of limitations from proning as well, especially when it comes to surgery.
Okay, thank you very much, Dr. Pans. Miki, do we still have time?
Yeah. So it's almost the time to end now. So,
okay.
Yeah.
But there are a lot of questions, and maybe the speakers can just leave their email to you, and they will be asking the attendees to send their queries to the respective emails. Will it be all right? Yeah. Okay. So,
sure.
Okay. Thank you very much. It was really a great evening. Very fruitful, enriching. We gained knowledge, wisdom, and knowledge from our experts and esteemed speakers. So, in behalf of the Philippine Society of Anesthesiologists, I would like to thank our doctors for attending this PSA Winsonic Dandelion College webinar. Now, as we come to a close, we in the PSA and Winsonic hope that we have given you a clear perspective of what lung ultrasonography is all about and the various clinical manifestations of COVID-19 patients using lung ultrasonography as well as cardiac ultrasonography. So I would like to express my appreciation, our appreciation actually, to our speakers. They're very good, Dr. Cano and Dr. Oliver Panzer, for sharing their time, knowledge, experience, and expertise. I was looking at the chat box and they were saying, congratulations, nice webinar, and I couldn't agree more. And thank you for all the attendees for spending your early evening with us. Stay safe, and good night. Thank you very much.
Dr. Valera,
Thank you very much.
for being our moderator. It's our honor for the president of the society to be the moderator.
Good. Yeah.
Thank you.
Oliver.
Actually, I already answered some of the questions privately a while ago. So I started to answer some of them. So to not pile up, because I was seeing there were a lot of questions coming in, so I already started answering a few of them a while ago. While Oliver,
tried a few as well.
Okay,
hey,
Oliver.
Thank you very much.
You'll be expecting a lot of invitations as soon as times get better. Expect some invitations from the Philippines. Yeah. Okay. Thank you very much.
Thank you, Oliver. Hope to see you again soon.
Thank you so much.
Yeah. See you soon.
Thank
Okay.
you.
Thank you, Miki.
Thank you, Doc.
Thank you, Joseph. Yeah.
Doc Valera. Thank you, Dr. Cano. Bye,
Yes.
Miki. Thank you.
And to the attendees, thank you for attending.
Thank you, everyone.
Thank you, everyone. Good night.